Okay, welcome to Neuro and Psych Pharmacology 2, going over sedative, hypnotics, anti-anxiety, and ADHD medications. We're going to go over sedative, hypnotic, and anti-anxiety agents first, and then ADHD agents second. So let's get started with just an overview of what the difference between a sedative is and a hypnotic. So a sedative, and a synonym for a sedative, is an anxiolytic. So to lyse something is to break it in half. You might have heard of autolysis, where some cell destroys itself. Anxiolytic means to lyse or break up anxiety. So a sedative is just meant to reduce anxiety, calm the patient, as opposed to an hypnotic. A hypnotic helps the patient fall asleep, and it may also help the patient stay asleep, though some medications only work to help the patient fall asleep. And the reason for that is we want medicine working for as little time as necessary. So if you have something that works late into the night, it may be artificial and the patient may not get good sleep. So hypnotic, though, is something that's going to help a patient fall asleep and in some cases stay asleep. Some of the medications are a sedative, some are a hypnotic, and others are both. Okay, so let's look at a specific class of sedative hypnotics, the benzodiazepine. And a normal neuron with gamma-aminobutyric acid, which we call GABA, receptor, and the action potential firing normally. So we have this receptor, we have the neuron, and then that action potential. Okay, so that's what works normally. Benzodiazepines bind and activate GABA receptors on neurons. The chloride ions enter, and then you need more electrical impulses to fire the action potential, and then the signal stops. So what benzodiazepines are meant to do is meant to make it so that GABA can now make it much harder for this to happen. All right, so the benzodiazepine comes in, the chloride goes in, and then the electrical potential just kind of stays here, or the action potential stays here and doesn't fire down the axon. Sedative hypnotics, so again, the benzodiazepines, one way to remember a few of them is to use the CALM mnemonic, C-A-L-M, C for clonazepam, A for alprazolam, L for lorazepam, and M for midazolam. And those are Klonopin, Xanax, Ativan, and Versed, respectively. So the indications for benzodiazepines are much greater than just sedative hypnotic, just for sleeping or insomnia. They're good for anxiety, panic disorder, sedation, anesthesia, premedication, and seizures. But in this part, we're just talking about the insomnia. Some of the adverse drug reactions we have are, certainly when the person wakes up, they may feel a little bit drowsy, or they may get a little even dizzy while they're taking something like this. They may find themselves confused, and then CNS depression is also a possibility as well. Here's a note, though. Benzodiazepine should not be combined with opioids. It increases the risk of CNS or respiratory depression. And it shouldn't be used long-term due to abuse potential. If you are or have to combine them in some way, we're going to need to make sure that the patient has naloxone, just in case there's some kind of overdose situation. Benzodiazepines, PO onset time, PO meaning per os or by mouth onset time. So how long would these oral tablets take to start working? It's quite important to know that if you're going to have someone who's having a seizure right now, we wouldn't give them a tablet to hopefully stop the seizure in an hour or something like that. We would rather use these for maybe there's an event that they're getting ramped up for, maybe there's some kind of presentation. It's important to know that it's going to be almost an hour before the alprazolam or clonazepam work, and lorazepam even maybe 2 hours. So if it's emergent, we would use something like midazolam, which is IV and works in minutes. But if it's something where we're going to have a situation where the patient's going to experience anxiety, to know that it's going to maybe take an hour or two before it really kicks in. Now, in terms of insomnia, what we really are worried about is that it impairs the person's daytime activity. So some people are sleeping for 5 hours and feel fine. Some people sleep for 7 hours and feel fine. Some people need more. But the benchmark is it affecting your day? How are you feeling throughout the day? And if you can't do the things that you normally need to do, go to work and those types of things, then that's insomnia. So the patient's symptoms are going to drive the individual treatment. If you're just anxious about things, and I don't want to say just, but if there's an anxiety component, we would treat that. And if it's a sleep component, then we would treat that. But individual treatment based on the condition. Benzodiazepine-like is actually not a benzodiazepine. They're structurally different, but the same mechanism of action. They produce only hypnotic effects, so they're only going to be used for sleep. But how do we decide between two, like S-zopiclone, which is Lunesta, or Zolpidem, which is Ambien? So with S-zopiclone, there's no real limit on the duration of use. So if someone needs it for 6 months, 9 months, something like that, this is what we would probably turn to, whereas Zolpidem we can only use for 3 to 6 months. There is a metallic aftertaste, and while uncomfortable, it's something that most patients can tolerate. But certainly if we don't have to have something like that, it would be nice to use the Zolpidem where we wouldn't have to deal with that. And then the adverse drug reactions are similar to benzodiazepines, but the advantage of these is that these are specifically for that sleep state and the hypnotic effects. Another form of a sedative hypnotic is a melatonin agonist. So again, an agonist activates, and melatonin in the brain is a hormone that produces sleep. Ramelteon, or Rosarem, and you can see the REM, like REM cycle at the very end of that, or Rose rhymes with doze. That's another easy way to remember what it's for. Instead of giving the patient melatonin, we're just going to activate the melatonin receptors as if there was melatonin there, and that will cause drowsiness. There's no abuse potential like the benzodiazepine and benzodiazepine likes. This isn't scheduled like the other one, so that wouldn't be as big a deal. And then there's no limit on the length of use, and the adverse drug reaction is very similar to placebo. So if a patient can use Ramelteon, it's certainly a good choice. Patients may try to self-treat and go over the counter before they ever go to a prescriber. And the first generation antihistamine diphenhydramine does produce drowsiness. We usually find it in acetaminophen with diphenhydramine or Tylenol PM. The Tylenol is there for pain because a lot of times pain will keep someone up at night, but the combination takes care of the pain, takes care of the insomnia, or tries to at least. So with these, though, we're going to see adverse drug reactions that are cholinergic or anticholinergic effects like dry mouth, blurry vision, constipation, which can be quite troubling for the patient. And it only works for a week or two because the body will become tolerant to the drowsiness and you'll still get the side effects. So this is a very short-term solution, not a long-term solution. Next, we'll do the anti-anxiety agents and talk first about what anxiety is. It's an emotional state from a real or perceived danger. So if someone is worried about something, it's still going to activate that same fear center that a real danger would, even if it's not going to happen. What are some of the characteristics? Apprehension and dread and fear and unease, deep discomfort, deep worry about what's going to happen in the future is a concern. It impairs normal daily functioning. So if the anxiety is a discomfort, like you don't want to go up and speak, but you do and it's fine, then it's very different than you're not being able to make presentations to keep your job or something like that. Possibly cause is serotonin and norepinephrine dysfunction. So when we're talking about how these drugs work, if we see that there's serotonin and norepinephrine dysfunction, then we know that maybe we could use something like SSRIs or SNRIs to treat, because if that's the underlying cause. And we can talk about it as acute or chronic. So an anxiety where certain instances or certain issues cause the anxiety is acute, versus something chronic where we have something that's a long-standing issue. They're continually dealing with anxiety issues, maybe obsessive compulsive disorder, things like that. So there are 5 classifications: generalized anxiety disorder, panic disorder, obsessive compulsive disorder, social anxiety disorder, and then PTSD, or post-traumatic stress disorder. Something like generalized anxiety disorder, we might start with an SSRI or SNRI. It'll take 2 to 3 months to see the full benefits, but we don't wait that long. If in 4 to 6 weeks we really see no response, or maybe just a small response, we might add a benzodiazepine, or we might add buspirone. But this is how we would deal with generalized anxiety disorder. A bit about buspirone. Or brand Buspar. We don't really know how it works. It might affect serotonin. It can take up to 2 weeks to be effective, but certainly much quicker than that, 2 to 3 months. It has to be taken a number of times a day, which is somewhat difficult for some patients. And we want to be consistent. If you take it with food, continue to take it with food. If you take it without, take it without. But that will affect its ability to do its job. Panic disorder versus panic attack. So a panic attack is an episode of intense, unprovoked fear. So something is just terrifying a person, and it's very quick in its onset, and it just kind of comes on the person. When we call it a panic disorder, it's going to be multiple panic attacks that continue to happen. And how do these panic attacks present? Certainly palpitations, or that pounding heartbeat, chest pain, shortness of breath, sweating, chills, fear of losing control, or fear of death. All of these things can precipitate a panic attack and really, really disable the patient. To treat something like that, we would use an SSRI with a benzodiazepine. We would use the benzo for maybe 2 to 4 weeks. SSRI should have kicked in by then. Or we can use an SNRI, serotonin norepinephrine reuptake inhibitor, like venlafaxine XR, and that might take about 12 weeks to be effective. We'll continue to treat for at least 6 months, and we'll hopefully have fewer relapse rates. Obsessive compulsive disorder, we want to watch out for obsession versus compulsion. So an obsession, it's a recurring thought that reason cannot remove, and so although logically you're saying, I shouldn't be thinking these things, you continue to think about them. When you have an action like washing hands or something like that, where you can't control that repetitive act, that would be a compulsion. So drug treatment, we would keep the patient on a selective serotonin reuptake inhibitor for at least a year. Social anxiety disorder, this is just a fear of an intense and recurrent fear of others' scrutiny, and a couple treatments we can use. If it's something chronic, we could certainly use the SSRIs, paroxetine or sertraline. But if it's something for performance, like I'm going to get up on stage in front of someone to speak, a benzodiazepine, which might start working after an hour or two, or a beta blocker, which can reduce the heart rate, that can be used for performance only. Social anxiety disorder. PTSD, well, the patients are continuing to re-experience a traumatic event in their past, and we want to actively avoid reminders of those. I remember a student asking if I could remove all mentions of firearms or guns from my exams because of that PTSD, and it was very easy to do for that student. So again, trying to avoid reminders. And then it's a persistent hyperarousal state, always in that fight or flight, ready to attack mode or ready to defend mode. Treatments that we have: fluoxetine, paroxetine, and sertraline as SSRIs, or maybe venlafaxine as an SNRI. The ADHD agents, we'll first talk a little bit about what ADHD really gets in the way of, and then we'll talk about some treatments. So in the prefrontal cortex, we have centers for planning and problem solving and short-term memory and behavior. There's more activity in the non-ADHD brain than there is in the ADHD brain. And what we want to do is, in some way, see if we can't help improve focus and allow them to plan, problem solve, remember, and improve their behavior. So the animation is just basically saying this is a lot more activity in the non-ADHD brain regarding these 4 big caveats. With this decreased prefrontal cortex neuronal activity, and I know that's a mouthful, but we're just saying that there's less activity, with increased dopamine and norepinephrine reuptake. So what we're saying is that the drugs are there in the synapse, but we are finishing up with them too quickly. So the medications will release or prevent the reuptake of that dopamine and norepinephrine, but the mechanism is a bit different than SSRIs and SNRIs, just to be clear. A couple of examples: methylphenidate, which you may know as Ritalin or Concerta. It's a 50-50 mix of levo and dextroisomers. And then there's dexmethylphenidate, which is Focalin, and you can see the word concentrate in Concerta for methylphenidate and focus in Focalin. Focalin is really just the dextroisomer, or the right-handed isomer of the levo and dextro mix. And so is it necessarily that much better? Maybe, maybe not, but that was the idea. We have availability as immediate release and extended release versions, because depending on when you are in the year, for example, if someone's using something like Ritalin for school, we wouldn't really want it to last too long if they just need help during school or for their schoolwork, which they do right after school. So we might move to an immediate release if we find that they're having some of these adverse drug reactions. One that's not on here is insomnia. That can happen if we give it too late in the day, and we'll talk about in the next slide. But adverse drug reactions, we can expect weight loss, maybe growth suppression, increased heart rate and blood pressure, psychosis, which looks very much like schizophrenia, and then if stopped abruptly, possibly withdrawal. So the 4 that I'll just put on this chart are methylphenidate, which is Ritalin, dexmethylphenidate, which is Focalin XR, methylphenidate is Concerta, or methylphenidate immediate release 3 times a day. And we see that these peaks happen somewhere around maybe 4 or 5 p.m., and then it gradually tapers off. But imagine if instead of taking it 7 a.m., the patient took it at 11 a.m. In that case, they would be wide awake for quite a long time, and we would want to take something like the immediate release and only maybe give 2 doses instead of 3, so that we avoid that insomnia at the end of the night. There is a non-stimulant, atomoxetine, which is Strattera. It's a selective norepinephrine reuptake inhibitor with no dopamine activity, and it takes a couple of weeks to see the effects and almost up to 3 months for full benefits. And it is less effective than the stimulants like Ritalin, but it doesn't have abuse potential. So it's kind of one or the other. Are you going to choose something that's a little more effective with a stimulant, or is there an issue with the abuse potential that we have to use this? And then adverse drug reactions similar to the stimulants. Note, there is an increased risk of suicidal thinking in children, very rarely, and it appears during the first several months of use, so certainly something to watch out for.